Okay, if I can get the first set of our honourable guest speakers to come up, and that will be Her Excellency Li Bin, the Minister in charge of National Health and Family Planning Commission for China, His Excellency Jagat Prakash Nadda, the Minister of Health and Family Welfare, India, His Excellency Isaac Adewale, Minister of Health for Nigeria, and finally Her Excellency Puan Maharani, the Coordinating Minister for Human Development and Culture, Indonesia. If you could make your way to the stage, thanks so much. Now, in the meantime, a bit of background about the aims of today's first session. TB is, of course, a concern to all people across countries and continents as one of the leading cause of global deaths, the leading infectious disease in the world. It does, however, inflict a disproportionate burden on a certain group of countries and vulnerable groups of people within those groups of countries as well. In 2016, 87% of new TB cases occurred in a group of 30 countries. 64% of deaths were reported in 7 of those countries also. Highlighting the experiences of these countries in fighting the epidemic and transferring challenges into opportunities is the key to ending the TB epidemic. Now, the panel today will enable participants to understand the range of approaches that these large population, large burden countries have undertaken to end TB. They'll recognize the needs of their communities and the specifics of the national healthcare agendas, political, administrative structures, as well as the nature of their epidemics. We can then take this experience, these targets that we set today and tomorrow over the next 48 hours, transfer them into action and take that momentum hopefully into next year and into the 2018 UN General Assembly high-level meeting in September 2018. Can I ask you to join me in welcoming our first set of guest speakers today? Thank you. Check. Thanks so much. Your Excellency Li Bin, if we could begin with you today. Thanks so much for joining us. Now, China has driven down TB prevalence significantly. There's been some outstanding achievements in your country, but there is still a very large burden. The country is currently finalizing a new round of health reforms. Now, the focus of them, of course, is to emphasize measures in increasing access to quality healthcare for those affected by TB, while reducing the financial personal burden as well. Could you just give us an idea, how are these reforms making a difference for taking the next step in people affected by TB and by MDR-TB? Thank you.
Okay. 尊敬的世卫组织总干事谭德赛博士，俄罗斯卫生部长斯科沃尔佐瓦女士，各位部长、女士们、先生们，大家下午好。结核病是人类健康的严重威胁。中国十分赞赏世界卫生组织和俄罗斯卫生部共同来举办这次遏制结核病行动的首届部长级会议，这对于加快落实联合国可持续发展目标和世界卫生组织遏制结核病的战略都具有重要的意义。
China appreciates the joint efforts by the World Health Organization and the Ministry of Health of the Russian Federation to host the first WHO Global Ministerial Conference, ending TB in the Sustainable Development Era, a multisectorial response. This gathering is highly significant for the implementation of the UN's Sustainable Development Goals and the WHO's TB strategy that aims to contain the epidemic by 2030. In his report delivered at the 19th National Congress of the Communist Party of China, President Xi Jinping stressed that the healthy population is a key mark of a prosperous nation and a strong country, recognizing its impact on the building of a moderately prosperous society in all respects and the realization of the Healthy China 2030 plan. China has attached great importance to the prevention and treatment of TB. In recent years, we have taken serious measures, including deepening our reform of the healthcare system to contain the epidemic. Here, I would like to share our progress and experience with all of you. First, adhering to a people-oriented approach and strengthening the top-level design, China has integrated the prevention and control of TB into its social development plan and the Healthy China blueprint based on different priorities. During the prevention and control of the epidemic, we have identified our goals at the national level that include 5 specialized goals. Second, taking law-based approaches in the scientific prevention and treatment of the epidemic, integrating prevention with treatment and focus on treating the disease to promote its prevention. Positive results have been witnessed after the country formulated the administrative measures to prevent and treat TB, implemented the patient registration system, established the government-led preventative mechanism that involves a multisectorial approach and the whole society, and promoted the approach that focuses on the 3 aspects, including prevention, treatment, and management. Over 98% of newborn infants have received a BCG vaccination. With a TB case detection rate of 95%, we have maintained a cure rate of over 85%. Third, increasing government subsidies to further lower the financial burden on patients. The central government has established a special fund for major public health issues that gives regular TB patients free access to anti-tuberculosis drugs and follow-up examinations. Government investment in this fund has increased from 260 million yuan in the year 2004 to 640 million in 2016. We have also implemented the National Basic Public Health Service projects through such measures as follow-up visits to patients and directly observe the treatment, DOT. The provinces have also been actively exploring methods to include TB in the coverage of new rural cooperative medical system. Fourth, providing tailored guidance with a focus on key populations and geographic areas. In the remote poverty-stricken areas where the prevalence is high, we have been promoting the approach that highlights active detection, healthy breakfast, and administering medications together. School entry health exams have been required to prevent outbreaks of the epidemic across schools. We have also beefed up TB screening among people living with HIV infection. A total of 21,000 who were found to be infected with both HIV/AIDS and TB were treated from 2011 to 2015. Fifth, raising public awareness of TB prevention knowledge through multiple channels. Professor Peng Yuang, wife of President Xi Jinping, has served as a WHO Goodwill Ambassador for TB and HIV/AIDS since 2011. She frequently amended publicity campaigns on the World TB Day to raise public awareness by visiting schools and communities. In 2012, China launched a campaign that aimed to mobilize millions of volunteers for TB awareness. To date, has attracted over 500,000 volunteers who are working to spread the knowledge of TB. Over 75% of the population is aware of the knowledge about TB. In 2006, the country established a major national science and technology project dedicated to the diagnosis, prevention, and treatment of TB. China is making all possible efforts In this field, TB incidence was reported to be 61 per 100,000 of the population in 2016. The figure has dropped by 18% from 2010 to 2016 at a rate of 3.2% per year, faster than the global average. The mortality rate has fallen by 22% to 2.3 per 100,000 of the population from the year 2010, reaching the level of developed countries. While containing the disease at home, China attaches great importance to the cooperation with countries worldwide, supported by its partners, including the WHO, the Global Fund, and the Gates Foundation. The country has been actively learning advanced technologies and experience to improve its prevention and control capacities. It has also engaged in bilateral and multilateral academic exchange and cooperation. China has contributed its wisdom to the global effort to end TB by sharing the Chinese experience at major international gatherings, such as the World Health Assembly and the Health Ministers Meeting of BRICS countries. Due to its huge population, China still sees a relatively large number of new cases every year. Prominent challenges that we have recognized include insufficient financing, a poor coverage of new tools for diagnosis, a low case detection rate of multi-drug-resistant TB, and inadequate safeguards for the patients. We will work hard for the Healthy China initiative by adhering to the health-centered approach. We will integrate the prevention and control of TB into our social development plan. We will improve the etiological diagnosis and the CDR of multi-drug-resistant tuberculosis during our ongoing reform of the medicine and health care system. We will better safeguard the patients by working closely with multiple sectors to include more effective drugs and diagnostics in our subsidies. To build the community of common destiny of mankind, China is willing to strengthen its cooperation with global partners such as the WHO and its member states. Thank you very much.
Thank you so much, Your Excellency. China was, of course, one of the few countries to hit the TB 2005 control targets, as well as meeting the 2010 UN Millennium Goals 5 years early as well. So some fantastic achievements going on there. And now from the past going on to future goals, and His Excellency Jagat Prakash, Nadda, Minister of Health and Family Planning for India. Welcome to today's plenary session, sir. Great to have you. Now, this year, the government of India set a very ambitious target to end TB by 25. Certainly a very bold strategy there. How are you addressing your top challenges to enable better access to TB care and pursuing that cross-sectoral action to do that? Thank you.
Thank you very much for asking me this question, and it is a very relevant question which you have asked. First of all, I would like to share with you that the Government of India attaches a great priority to end tuberculosis, and that is why our Honorable Prime Minister, Shri Narendra Modi ji, has come out with a very bold declaration that we will end tuberculosis in India by 2025. As we all know that the Union General Assembly resolution and the Sustainable Development Goal is to end by 2030, but India plans to go forward and end tuberculosis by 2025. It is a very ambitious plan and a very aggressive strategy we have to develop, which we have developed as yet. Our Prime Minister is very keen to see to it that we go forward in this direction in an aggressive manner. And personally, he's monitoring from time to time the strategies which is being developed and being implemented in the country. As far as the first step which we have taken is that we have come out with a national strategic plan. And this national strategic plan has been made in consultation with all the line departments, and we have developed a multi-sectoral approach where we have to address the issue of tuberculosis not only by the health department but other line departments also. So we have taken a very comprehensive approach and multi-sectoral approach, which is the agenda of this conference. So that multi-sectoral response is also taken in our national strategic plan. We have got 4 pillars of this national strategic plan. Number 1 is to detect, and that to early detection of patients. And the another is treat. And the third is build up the structural aspects which is needed for addressing these issues. And then it is for to prevent. We have to also go for prevention. So these are the 4 pillars on which we are working. We all know that if we have got an ambitious plan and if we want to go in an aggressive manner, we need funds also. I'm happy to share with you that all these plans have been supported financially also. Practically $3 billion are being spent for this prevention, and this is being done by domestic funds, and we have seen to it that free detection, free prevention, and free medication is to be done, and that is to be done by the Government of India by its own kitty, by its own financial resources. Thank you. Our challenges are that we have to reach the unreached. India, with 1.25 billion people, many residing in the tribal areas, many residing in the far-flung areas, which are inaccessible areas. So that is one aspect which needs to be addressed and where we want to reach to them. And for that also we need finances. And for that, and one more area of challenges, registration of the patients who are being taken care in the private sector. Many tuberculosis patients are unregistered who are being treated in the private sector. So these are the 2 areas where we are going in a very systematic manner and trying to see to it that we reach them. And for that, another 25% of the budget is earmarked to see to it that we reach the unreached. And that is one aspect which we have taken into consideration. One aspect is that we need social and nutritional support. It's not only possible that we give them treatment or we give them medicines and that is going to work. We have to give them social protection. We have to see to it that they're socially taken care of, and also nutritional aspect is also to be taken into consideration. So these 2 aspects, for that also special micro-level planning has been done, and now we are implementing it. And we are trying to see to it that the nutritional support reaches the patient and he's able to have a better living. And for social security, the other multi-sectoral approach we have adopted so that we see to it that their issues are addressed there at the local level. We have started a program which is called as JAN. J stands for Jan Dhan Yojana. This means that every patient we ensure should have a bank account, and he's connected, and that bank account is to be opened without any input, without any, he's not supposed to deposit any money to become an account holder. With 0 account, he can open an account and he'll be an account holder. Number 2 is the Aadhaar card, that is the UID card, unique identification number, which is correlated and connected with the bank account. And the third is the Nikshay. Nikshay means online registration of a tuberculosis patient. So with this JAN, all the funding of nutritional support and the social support will come from the health department directly to his account for his support, and this is how we are trying to give him, ensure him social security and social support as well as nutritional support. We have, as far as the treatment is concerned, we have gone forward. We have improved our regimens. Daily regimen has been introduced. We all know with our experiences that weekly regimen has now, it is being preferred to go for a daily regimen, and we have introduced daily regimen. We have gone for shorter regimen. Use of bedaquiline has started. And you will be happy to note that with this NICSHE, last year only, some 300,000 patients of tuberculosis were registered from the private sector last year, and they have been registered and free medication has been given to them. 300,000 patients added because of this NICSHE program, online registration program. We have gone for an active search campaigns, and this active search campaigns we have done 2, and I would like to share with you that this active search campaigns have been done in 257 districts. Approximately 30 million people have been screened, and out of 30 million people, 15,000 active tuberculosis cases have been detected. And now we are continuously going for an active screening program so that we are able to address this issue. As far as the detection is concerned, we have gone for a gene expert machine. And it's enlightening to note that India has got, every district has got now a gene expert machine. And now we have got the approval of TrueNat machine. So we want to see to it that our community health centers and primary health centers are supported with this TrueNat machine, so that we go for a reliable early detection as far as the tuberculosis patients are concerned. The fixed dose combination has been introduced for the drug sensitive, and it is introduced newer drugs which are TB resistant, drug resistant TB, that is also taken into consideration. We have tried to see to it that we improve our health systems, and strengthening of the health systems through National Health Mission. Approximately $6 billion we are spending yearly, and it is not being spent on the planning done by at the central level, but the micro level planning done at the grassroots level. Those planning is being supported financially by the Government of India through National Health Mission, and we are strengthening our health systems so that we are able to give better support. As far as the effective TB surveillance program is concerned, we are aggressively going on that issue. India has taken few regulatory steps. We have banned the commercial serology, and we have also brought change in the Cosmetics and Drugs Act, and we have put tuberculosis on H1 schedule. That means every chemist, as well as the doctor, as well as the dispensing authority, will have to keep a register, and they will have to see to it that to which patient this drug is being given. So that way a regulatory mechanism has been developed. Notification of tuberculosis has been made mandatory, even in private sector, and that is how we are able to detect more cases and address them. We all know that India is producing 80% of the world drugs as far as the tuberculosis is concerned. India is manufacturing 80% of the drugs. We are trying to see to it that now we go for generic drugs, which will be cheaper for the country also, and also for the world over. And so that we are able to reduce the cost of treatment of tuberculosis. So in this also, we are strategizing and going forward so that we promote generic medicines. So as I said, that our Prime Minister has taken a very bold decision to end TB by 2025. Multisectoral approach has been developed, and we are trying to see to it early detection, free treatment, and prevention, and sensitization, and reaching the unreached, and also providing the daily regimen and if cost-effective drugs to the patients. This is how we are going forward. Thank you very much.
Thank you so much, Your Excellency. It's very obvious from your presentation as well the importance not only of medicinal reforms, medicinal action, but also reforms, as you mentioned, in social security, in business, and other areas as well, to have that cross-sectoral approach to tackling this. I'd like to now go to Your Excellency Puan Maharani, the Coordinating Minister for Human Development and Culture for Indonesia. Thanks for joining us today. Now, Indonesia is working very hard to reach the unreachable, their so-called patients that may not have access right now to TB treatment. Now, can you tell us which health reforms in your country specifically are set to increase the inclusion of those patients which may currently not have that access, and also to enable access to improved diagnostics and drugs as well? Thank you.
Excellency, ladies and gentlemen, it's a great pleasure for me to be here together with distinguished ministers, colleagues, and friends from all over the world who are fully committed to end TB epidemic in the world. Our challenge as high TB burden countries in ending TB is high missing cases that not been notified in our program. Hence, our main activities are to find all TB cases and to treat them as well as notify them in order to stop TB transmission and its spread. For this purpose, we have to overcome many obstacles, such as the difficulties in accessing TB cases spread out in rural and urban areas, limited resources, geographical remains, and socio-economic problems. Finding new ways and creating innovation in order to detect as many as possible TB cases to be treated, to mobilize sufficient resources, and resolving socio-economic constraints are crucial to be carried out. This can be well implemented when strong commitment of all government sector is in place with strong support of the community and all parties concerned, including the private sector. Indonesia takes pride and is fully committed to adopt and aims at achieving the elimination goals and targets as defined by the TB strategic and development goals. Our commitment for achieving the elimination of tuberculosis are ensured by the government of Indonesia's policy through strengthened self-reliance and sustainability in TB control, which include, first, the implementation of exit strategy of external aids for TB control. Second, carrying out national health insurance and social protection schemes. Third, conducting family health and community approaches. Fourth, stabilizing district-based public-private mix strategy. Fifth, practicing active case finding and partnership. And sixth, engaging innovative policies in TB control. These are 6 keys to improve the access and outreach of the previously unreached TB cases. Additionally, legal framework, which includes declaring TB is notifiable disease, has been strengthened to support TB control in achieving the elimination of tuberculosis. With regard to improving TB case detection, Indonesia has started the family approach in healthcare by conducting home visits in order to detect TB, treat it, and other health problems in family to be solved. For health risk factor control, we are now carrying out the healthy lifestyle movement to motivate the community to practice healthy lifestyle. Ladies and gentlemen, may I conclude by emphasizing Indonesia's strong commitment to achieve the elimination of tuberculosis by 2030 as part of the nation's development agenda. TB affects all. TB is everyone's business. Thank you all.
Thank you, Your Excellency. And we understand that some of the measures you've implemented, namely the cooperation, as you mentioned, between private and state health providers, that's been key in reducing incidence of TB in the country, as well as those active case-finding measures you mentioned there as well. Finally, I'd like to go to Your Excellency Isaac Adewale, Professor, Minister of Health, Nigeria. Thanks for being with us here today. Now, Nigeria is also in the middle of national primary healthcare reform. We've also got some very ambitious targets, building 10,000 primary health centres throughout the country by next year is just one of them, certainly a very ambitious measure as well. Your strategy aims to integrate under one roof a lot of these medical services to reduce fragmentation in how TB is tackled. How is this policy being used to escalate the delivery of treatment and access to treatment of TB? Thank you.
Your Excellencies, Mr. Moderator, dear panelists, it's my delight to be not only a witness, but to be a participant at this landmark event in a collective journey to end a global problem. As we will realize, this will also lead to a high-level meeting next year. And to me, what is historic about this is TB that no one would want to talk about in the past now has become a frontline issue. And to me, this is very historic. And we must really congratulate ourselves for being able to achieve this. Well, what is also important is to recognize that the battle is not going to be a short one. It's going to be a long-term battle. We must all remain committed to getting things solved. And we will also move from rhetoric to action. For us in Nigeria, as you will recognize, we are one of the eye-burden diseases. We are number 2 in Africa. We are also one of the 30 eye-burden countries and one of the 10 that really constitute about 76% of the global body. So that, to me, represents the real challenge that we are facing in Nigeria. But what is also important about Nigeria is that a 2012 survey indicated that we are only able to detect about 1 out of 6 cases of TB that we have in Nigeria. And that, to me, really is the major challenge. How do we find these cases? Because for as long as they remain unlocated, they're going to infect other people. And that's why we're using the opportunity of the reform in the eye system to really locate these cases. The government has launched an ambitious project using primary care revitalization as a fulcrum for achieving universal coverage. And what we're planning to do is to put life into about 10,000 of our PSCs across the country in a way that we can reach about 100 million poor Nigerians. And since we know that TB really is a major problem among people, we believe that this will be a major platform for achieving this. And what we're doing in the context of the revitalization is to make TB part of a package of basic care. We are not really just picking out TB. We're looking at how to institutionalize a package of care, looking after malaria, looking after TB, looking after HIV. To us, this is where we want to go. And each of the revitalized PSC will be able to diagnose those cases. And then we'll build an effective referral system from the primary to the secondary and to the tertiary in order to ensure that we offer the care that our people deserve. Not only this, we are also reaching out to the community. We want to do things differently. Someone said that if you keep on doing the same thing the same way and hoping to get a different result, one can be accused of insanity. So we're trying to do things differently. What we are doing now is to also use innovative approaches. We've put in place the use of GeneXpert machine. So far, we've deployed about 386 of these machines in our districts. Our target is to get to 774, where each of our local government will have a GeneXpert machine. And to us, with GeneXpert machine, we'll also be able to detect resistant cases. Not only that, we've deployed with the support of the USAID KICV TB program, we've deployed what we call a wellness on wheel machine. We call it WOW. These are machines, vehicles with a digital X-ray. We have a GeneXpert machine on board the vehicle. We can diagnose malaria, we can diagnose HIV. And that to us, we will then move door to door so that we're taking healthcare and diagnosis to the doorstep of the people. We will remove stigma and discuss this openly. Not only that, the wife of our president has become a TB ambassador in order to raise TB to a political level. We've also made our governors TB ambassadors. And what we did at the last meeting of the National Council on Health is to make each of the commissioners of health a TB ambassador. In other words, we're elevating the discourse on TB to the public level. Everybody now should feel free to talk about TB. will remove the stigma and remove the shame associated with TB. In addition, we are also removing cost barriers, because these are some of the challenges. We want to make sure that we can diagnose you free, we can treat you free, and provide support. So that we are not only looking at case finding, we are looking at treatment, and we are also offering shorter regimen treatment in order to make sure that people comply. For several years, we've been applying DOT, direct observed therapy, where we make sure that they take the drug. So we're putting together a basket of efforts to make sure that these are done. We will not only improve efficiency, we will also reduce wastage, we will reduce fragmentation, and also ensure that things are put together. We are also employing innovative partnership with the private sector. We are ensuring that even private hospitals and health facilities also make TB notification a precondition for annual registration of their licenses. So we want to make sure that you are compliant. If you don't comply, you will not renew your license. So we want to make sure that every opportunity that we have to pick TB, we really employ. Our strategy is anywhere there is TB, we find TB. We want to discuss TB openly. There's no shame about it. We're telling people it is preventable, it is treatable, and it is free. And to me, we believe we achieved some tremendous results. Between 2016 and 2015, we've achieved a 7% increase in TB case finding. We have dedicated 2017 as our year of accelerated TB case finding, so that we can improve on TB case detection in the country. And we believe that through all these approaches, Nigeria will move forward with detecting more cases, offering treatment to our people, and contribute to the global effort to ending TB by 2030. Thank you.
Thank you so much, Your Excellency. Some very key points you mentioned there. One of them, not mentioned before, the importance of raising awareness, of getting rid of stigma to ensure people do come forward, get diagnosed, and get the treatment they need. We will now have another very short technical break. Do stay seated for that. If I can send our current speakers back to take their seats. Thanks so much for talking to us today. And in the meantime, if I can ask our next set of distinguished speakers to in turn make their way now to the stage for us. That's Her Excellency Saira Afzal Tara, the Minister of State for National Health Services, Regulations and Coordination, Pakistan. His Excellency Piasakol Sakol Satayadorn, the Minister of Public Health for Thailand. His Excellency Antonio Carlos Figueiredo Nardi, the Vice Minister of Health, Brazil. And last but not least, His Excellency Aaron Motsoaledi, the Minister of Health for South Africa. Thank you so much. Okay, Your Excellencies, thanks so much for joining us on the second half of this plenary. If I can ask you all to show your appreciation as well for our next set of distinguished speakers at this afternoon's event. Thank you. Now, Your Excellency, Saira Afzal Tara, if I can perhaps start with you on what's going on in Pakistan. A bit of an interesting case there. The national health system has been devolved to give more powers, more authority to the larger provinces to address their healthcare needs. Can you tell us how exactly you work with your leaders, the healthcare providers in provincial levels, district and municipal levels as well, to increase their actions and their access to TB healthcare? Thank you.
Thank you very much. Bismillah ar-Rahman ar-Rahim. First of all, I must appreciate and congratulate WHO and Russian government for organizing such an important event. And I think the number of participants shows that how important this TB and program is. Now the problem, I was just listening the statements from all the ministers. Now there was a time when in 1960 streptomycin injection was introduced, and that was a revolutionary step in this treatment regarding TB. Start from that day till now, so many innovations, so many medicines, and so many steps we have taken. But what I feel as a developing country, I mean, first we have to look into the reasons and the causes why TB occurs. Now the gap, unfortunately or fortunately, the basic funding which we are getting, that is from Global Fund. And we all know that TB kills the most productive age of the human beings. And it also affects your economy and also your social structure. So when I become a minister, the domestic funding of Pakistan was very low. So you ask about devolution after devolution. The role of the federal ministry is to coordinate, to regulate, and also to make advocacy and convince our provinces that where you have to put your resources. The first thing which we did as far as TB is concerned, we make a strategic 3-year plan, a costed plan, which was about $500 million US. The amount which we are getting from Global Fund, that is 143 million. So that the gap which was, I'm pleased to announce that at present, one of our province, Punjab, so we convinced them to add their own resources. So 34 million plan, the PC1 which they have made, that is from the own provincial resources. The second thing which you talked to the Prime Minister, that only the thing which began while distributing the different shares, the way we call NFC award, why don't you ask provinces that they must allocate the certain amount for health sector also? So which we have started, and when all the chief ministers are there, the health is also an issue which they discuss for allocation of resources. In a country like Pakistan, and I think everywhere, what we need is for any eradication, elimination or program, there are 3 main pillars. Number 1, political commitment. When we talk about political commitment, it's a very vague statement. Political commitment not at the floors or in the speeches, allocation of resources. And the second is personal monitoring. I mean, I just feel I can say that we are among those countries who are still suffering from polio. Now we are at the last mile. And the reason being that we work as a team. Federal government, provincial governments, partners, law enforcement agencies, civil society. And I think if you want to prove something, I think that is an example that how we can make that. The second thing which I must say that I will go into not that detail, the genome machines and X-rays, digital machines, and how we are going to that. But what we need is, we always talk about multisectoral approach. I think we have to look at, you also asked, at the district level. District level and then going to the district, down to the union council level, that is an area where we need a multisectoral approach. There are so many people working, but we working in, isolation. And the second major challenge which we are facing, that is in MDR, multi-drug resistant TB. Almost we have 5,000 cases. But through Global Fund, we have been able to treat only 1,500 patients. What about the rest of them? And we all know that MDR treatment is very expensive. So what we have started, that we have included in the PC1 of the provinces and all the federally administrative area, that start treating from your MDR patients. So we have started from 500. So every province will treat 500 MDR patients apart from Global Fund funding. So they have agreed to it. Another thing which we have done is that, I was just listening to Indian minister also, the treatment, the patients which are treated in private sector, we don't have that data with them. So what we have done a legislation in all the provincial assembly and also the national assembly, that private sector, it is mandatory for them to report the TB cases to their national registry. And after that, definitely, I think there's a sensation in the private sector. Also through general practitioner, we have been taking care of. We have deducted almost 100,000 patients through private sector. Another challenge which we are facing, at present we are treating 300,000 patients, but at the same time we are missing 100,000. So what about those 100,000? So I think it's good that at this level and even at country level, we have started looking at that what the gaps are. We have to stand our own feet, and I think we can't depend on Global Fund and WHO. It's our people, and I think the ownership, the only ownership which we have is that we are committed to our people. And I always say that all those programs which we run through donors, donation, the government ownership is not there. So this is for the first time that everybody and whatever we are committing, we are owned to that. And I think the last thing which I want to say is that at district level, now we are talking about MDR-TB. You know, in Brazil, we were talking about hepatitis. Maybe in next conference, we will be talking about another disease. So what we need to do is that at district level, provincial level, all vertical program, health issue diseases, we must have data, we must allocate resources, and then we must focus on monitoring how we are going to implement it. So I always say that already, I mean, we have smallpox example with us. So we can eradicate or eliminate such diseases, but only through targeting the right thing and allocating the resources. And I always say, together we can make a difference. Thank you so much.
Thank you so much, Your Excellency. If I could go next to Your Excellency, Minister of Public Health of Thailand. Your country's also undergone some reforms, and they've actually been described by some as the most ambitious public healthcare reforms in any developing country. The UHC policy has been at the forefront of tackling TB there as well. How is Thailand using that success, harnessing it and using it as momentum to help drive TB's decline faster in your country? Thank you.
Thank you so much, Daniel. Well, I would like to respond with two key messages. First, UHC is not the panacea for all health problems. The situation that Thailand being at the top rank in all three dimensions of TB challenges, in spite of having achieved UHC for 15 years, proves that universally available on free comprehensive TB service under UHC is not enough to tackle the challenges. For example, in spite of UHC, only 70% of the estimated TB cases receive treatment with only 75% success rate. This means only 53% effective coverage. Furthermore, only 70% of TB who are also HIV positive receive ARTS, and 30% of relapse cases receive drug sensitivity test. So we must be realistic and understand the limitation of UHC. Second, apart from UHC, we need a systematic approaches led by strong and committed champions to ensure sustainable successes. It is clear that our remaining challenges are not from lack of technologies, but from inadequate management and leadership. What we have formulated a systematic approaches called PROP, P-R-O-P. P stands for political commitment. We have just get strong political commitment through the cabinet approval of the National Strategic Plan on TB Prevention, Treatment and Care 2017 to 2021 to halve the incidence of TB in 5 years. This is the political or policy power that will ensure adequate resources, aggressive intersectoral action with clear targets. R stands for research and development. We have just started implementing a research package on TB and established a tuberculosis research network to develop and mobilize all social technological innovations, including genetic technologies. That is the power of wisdom to allow effective prevention among high-risk groups, very fast and early diagnosis, and effective short-term treatment, as well as destigmatization. O stands for ownership. We are moving to make the movement of TB owned by everyone. Every community, every agency, every health professional, and especially every affected people. This is a social power that will ensure zero stigmatization, strong community engagement for active, effective prevention, outreach, early diagnosis, and good compliance toward successful treatment, especially those high-risk priority groups, including people in close contact with the patient, people living with HIV, migrants, urban slum, and prisoners. And the last P, it stands for persistent actions by champions. We need the collective and continuous efforts of champions from all walks of life at all levels that will link the political, social, and intellectual power to form a superpower that will ensure real and sustainable effective coverage of active case findings and highest success rate without stigmatization. Mr. Moderator, our next immediate step is to identify and mobilize not just one national champion, but many collective champions from all walks of life at all levels. Champions who have high social and intellectual capital, champions who are fully committed every second to eliminate TB, and champions who will never stop their commitments and actions until the last day of their lives. We are very glad to be here to share and learn from other high-burden countries. Our collective wisdom will ensure sustainable global success in time of sustainable development goal targets. Thank you.
Thank you so much, Your Excellency, as well, raising some important points, in particular to do with targeting the most vulnerable groups to TB. And I believe we can go now to Her Excellency, the Vice Minister of Health for Brazil, Antonio Carlos Figueiredo Nardi, who can talk a bit more about that. Brazil, of course, has a moderate incidence of TB, but you have been working hard to target those particularly vulnerable groups mentioned, prisoners, the urban poor, those who've perhaps got other immune-affecting diseases, really address the social issues that go hand in hand with TB infection as well. What challenges do you face in Brazil, and how are you meeting them to move forward in tackling the incidents in your country? Thank you, sir.
Senhor Moderador, senhoras e senhores ministros da Saúde, senhores e senhoras embaixadores e membros do corpo diplomático, representantes das organizações internacionais e demais autoridades presentes. É para mim um motivo de grande satisfação participar dessa importante conferência ministerial sobre tuberculose. É uma honra para o Brasil compartilhar nossa experiência no controle dessa doença que ainda mata milhões de pessoas em todo o mundo e articular uma resposta global para essa ameaça de saúde pública. Estamos cientes da responsabilidade do Brasil nas Américas como o país que concentra 1/3 dos casos novos de tuberculose na região. Como mencionado, apesar do Brasil ser considerado um país de alta carga da doença, temos uma incidência relativamente moderada. Isso quer dizer que a maior parte dos casos da doença está concentrada em certas populações vulneráveis, moradores de periferias dos centros urbanos, a população privada de liberdade, as pessoas vivendo com HIV, a população indígena e as pessoas em situação de rua. O Brasil tradução.
I believe the delegations have been given a copy of the speech of the Vice Minister of Brazil. There's no translation in English on here, but they have copies.
O Brasil notifica cerca de 70 mil casos novos de tuberculose por ano. Não está traduzindo? Não, ok. Em um país com mais de 200 milhões de habitantes, corresponde a uma incidência de 34 casos a cada 100 mil habitantes. No entanto, o coeficiente de incidência varia de 11 por 100 mil, em lugares como o Distrito Federal, e 64 a 68 por 100 mil nos estados do Rio de Janeiro e Amazonas, respectivamente. Devido às particularidades dos estados e municípios, o Ministério da Saúde desenvolveu, em parceria com gestores estaduais e municipais, organizações da sociedade civil, inclusive aqui presentes, e representantes da academia, um plano nacional pelo fim da tuberculose. Em um país de dimensões continentais, a fim de contemplar as diferenças locais, definimos cenários para auxiliar na identificação das prioridades e estratégias a serem consideradas no plano de trabalho dos estados e municípios brasileiros que contribuam para o fim da tuberculose no Brasil. O plano brasileiro está alinhado às diretrizes da OMS e dividido em 3 pilares: prevenção e cuidado integrado, centrado na pessoa com tuberculose. O segundo, políticas arrojadas e um sistema de apoio. E terceiro, a intensificação da pesquisa e inovação. No primeiro pilar, estamos expandindo a rede de teste rápido molecular, totalizando 300 máquinas para o diagnóstico precoce da tuberculose e da tuberculose resistente. Um dos critérios para a definição dos locais onde as máquinas foram implantadas foi a cobertura do diagnóstico para populações mais vulneráveis. Realizamos uma parceria com o Ministério da Justiça para uma campanha de combate à tuberculose em todas as penitenciárias do Brasil, possibilitando o diagnóstico precoce dos casos na população privada de liberdade. Implantamos recentemente um sistema de vigilância do óbito com o objetivo de identificar as condições individuais e de acesso aos serviços de saúde dos pacientes com tuberculose. Com a intensificação das estratégias de vigilância, esperamos qualificar as informações brasileiras referentes aos óbitos. Para que possamos identificar e prevenir o adoecimento precoce, instituiremos o sistema de vigilância na infecção latente por tuberculose. E para o enfrentamento da tuberculose droga resistente, o enfoque é na organização da rede de atenção e na vigilância da resistência, incluindo novas drogas nos esquemas terapêuticos. Sobre a resistência aos antimicrobianos, tema de grande relevância no cenário atual, destacamos as ações voltadas para o enfrentamento da tuberculose resistente no nosso Plano Nacional de Resistência Antimicrobiana. Por fim, as diretrizes para o controle da infecção da tuberculose nas redes de atenção primária, secundária e terciária também estão sendo revistas e atualizadas. Nas articulações com outros setores, objetivo do segundo pilar, destacamos as parcerias intra- e intersetoriais com diferentes atores relevantes para o enfrentamento da tuberculose. O Ministério da Saúde tem uma importante articulação com a Frente Parlamentar de Luta contra a Tuberculose e, juntos, poderes executivo e legislativo trabalham estratégias voltadas para o enfrentamento dos determinantes sociais da doença. A parceria com o Ministério do Desenvolvimento Social possibilitou a integração dos serviços de saúde e assistência social para beneficiar os pacientes com tuberculose. Neste tema, a academia e organismos internacionais têm cooperado para a realização de estudos que comprovam a importância da proteção social para a pessoa com tuberculose. Sobre a intensificação da pesquisa, terceiro pilar do Plano Nacional, o Brasil foi um dos fortes impulsionadores para o lançamento da Rede de Pesquisa em TB dos BRICS, composta por representantes de governo e academia. A rede tem por objetivo identificar as prioridades de pesquisa e formas de cooperação para avançar no enfrentamento à tuberculose e alcançar as metas dos ODS para 2030. Os programas de tuberculose municipais, estaduais e nacional têm sido capacitados para o desenvolvimento de pesquisas operacionais que respondam aos questionamentos levantados pelos próprios programas de TB, fortalecendo assim a definição de políticas públicas em tuberculose baseada em evidências. O Ministério da Saúde trabalha em franca parceria com a Rede TB, Rede Brasileira de Pesquisa em Tuberculose, que é formada por diversas instituições e pesquisadores de todas as regiões do Brasil e contribui no desenvolvimento de novos medicamentos, vacinas, testes diagnósticos e estratégias do controle da TB. Essa articulação permitiu o desenvolvimento de uma agenda nacional robusta de pesquisa em tuberculose. Senhoras e senhores, o Brasil prioriza a Agenda 2030 de Desenvolvimento Sustentável. Nossas políticas e ações estão orientadas na perspectiva integral da saúde como prioridade inequívoca para a promoção do desenvolvimento sustentável e para a melhoria do bem-estar e da qualidade de vida. Sabemos que o enfrentamento da tuberculose exige ações coordenadas e contínuas. Trabalhamos para que a tuberculose siga como prioridade de governo, assegurada pelo presidente Michel Temer e o nosso ministro da Saúde, Ricardo Barros, visando o seu fim até 2030. Expresso uma vez mais meu agradecimento ao governo da Federação Russa e à Organização Mundial de Saúde por organizarem essa importante reunião, iniciativa inédita sobre o tema. Estou seguro de que seguiremos trabalhando para a melhoria efetiva de nossos sistemas de saúde e pelo desenvolvimento social e sustentável de nossas populações, alcançando o fim da tuberculose como um problema de saúde pública. Muito obrigado.
Thank you, Your Excellency. And just to clarify, there was no English channel translation there, but if you haven't got a copy already, copies have been made and will be made available to all delegations of His Excellency's speech there, highlighting the importance also of social policy in tackling the TB epidemic and also really harnessing the power of higher education institutions and other academies in order to really increase that R&D speed to tackle drug-resistant TB. I'd like to go now to our final speaker, His Excellency Aaron Motsoaledi, Minister of South Africa, Minister of Health for South Africa. Your country's been one of really the pathfinders on the continent for driving a political attention to TB and also really linking it to other diseases like HIV, among others. And you've really led this effort at home, Minister, in South Africa. Can you tell us some more on your vision for the next steps in South Africa in achieving those goals for 2020? Thank you.
Thank you very much. Well, the first thing I would like to say is that I believe the destiny of my country, South Africa, is inextricably linked with the destiny of the whole world in achieving the eradication of TB by 2025 and even reaching the 2020 targets. Maybe let me start here. I joined the board of the Stop TB Partnership in 2010, and there was always a question that we were asking ourselves, that over the past 200 years, TB has killed more people than HIV, bubonic plague, Ebola, malaria, cholera, polio, influenza, all of them added together. But we are not able to make any audible noise on talking about TB than any of these other diseases. I still remember in 2010, we had a 5-day retreat in New York to try and find out how do we generate enough noise for the world and for everybody to understand this problem caused by TB. So I regarded my mandate then as to make noise as a Minister of Health, but also as a chairperson of the Stop TB Partnership, to make noise into every ear that matters. And that's what I went about doing. The first noise I made when I got an opportunity was at the Lung Conference, Lung Union Health Conference held in Barcelona in 2014, where I was now wondering, why are we having 90-90-90 for HIV/AIDS and no 90-90-90 for TB? And I'm happy that this was taken up and it's happening. The second noise is that the Right Reverend, the Right Honourable Nick Herbert, a member of Parliament in the UK, have already proposed the establishment of the Global TB Caucus of Parliamentarians. And I joined in with him as a co-chairperson of that to mobilize MPs around the world. And I'm happy that 2,300 members of Parliament in 130 countries are now active, some of whom are in this conference today. Now, back home, one of the biggest areas of prevalence of TB in South Africa is in the mining sector, especially the gold mines. I'm sure many people might be aware that by the 1980s, 80% of the gold of the world was produced in South African mines. And it was not only produced by South Africans, it was people, especially around the South African development community. Now, today we are paying the price of producing that gold because there's a very high level of TB in the mines associated with gold due to the high level of silica dust that gold mining produces. So we have to bring all those people together. The mining bosses, the mining houses, the trade unions working within the mining sector, governments, and especially within the SADC region. And we're able to achieve that. We've been able to bring them together. And I'm happy that the noise was heard by the Global Fund, the World Bank, the German Development Agency, USAID, among others, who came in to try and fund such a venture, and it is going very well. Now you asked me about the vision. My first vision is about these short treatment regimens, which we spoke about here. to avoid sometimes people with extreme drug-resistant TB having to take 20,000 pills within a period of maybe 4 years or 24 months, the period within which they get treated. If we get shorter courses and also get pediatric formulations, that will be very wonderful. It's one of the visions that we must live. The second one is about data. As we all know, we can only establish our success or lack thereof if we have got good data that we can use to monitor progress. Very often, the data that is presented in a manner that is not user-friendly. I am happy to announce that the Stop TB Partnership has at long last developed individual country dashboards that represent data in a manner that allows individual countries to be able to interpret, and this can easily be monitored. And also to find the missing 4 million that I've spoken about. I said in my own country is 150,000. But my biggest dream of all, if I may say a final word, my biggest dream of all is that, when we come back from United Nations high-level meeting, I would like all heads of states to spontaneously, without reading because it appears on a prepared speech, but to spontaneously talk about ending TB on their own, with passion, with consciousness, with vigor, in most of their appearances when they talk to their citizens within their country or speak to their counterparts or in whatever world forum. I would like them to spontaneously mention this thing of stopping TB, because that's not what is happening at the present moment. I'm not trying to point fingers at everybody, but it's very difficult to find any head of state just to stand spontaneously and talk about TB. Those who did is because it's written somewhere in a speech. And I'm hoping what we'll achieve in New York is for them to understand, because here is a disease that is killing more people, even presently, than any of the other infectious diseases that we have ever known. So that will be because once that happens, I think lots of things will start following, including, raising own funds within own countries, including the issue of research and development, including the issue which the young lady from Kenya spoke about, which was very touching. The fact that in order to end TB and HIV and AIDS, we're not going to do it as learned health professionals. We need community health workers that are employed by the state. And if heads of states can understand that community health workers must become part and parcel of the health workforce in each and every country, then the dream of ending TB will become a reality. Thank you.
Thank you so much, Your Excellency, Minister of Health for South Africa. You mentioned there the passion, the vigour needed by heads of state. It will be fantastic if we could harness the passion, the vigour that we've seen so far at this conference. We'll see more of it over the next 2 days, really turn that into a collective, cooperative action, so that when many of you will meet here again at the UN High-Level Assembly in 2018, we can really take things to a new level and recognise the achievements that will have taken place by then as well. In the meantime, that brings the first high-level plenary session to a close. There will now be a break for lunch and for the ministerial lunch as well. And if I can ask the participants to be back in the room for 4 p.m. If possible, that would be fantastic. And just one more round of applause for our distinguished speakers here with us today. Thank you so much. Thank you so much.
Thank you.
Thank you. Thank you very much, sir. Great to have you here.
Brasília.
Thank you very much, sir.
Brasília and São Paulo.
São Paulo.
Yeah, I've been there
Thank you very much.
last year.
Oh, it's good. É, very.
Obrigado. Thank you so much, sir.
Thank you.
Thank you. You want this?
Yeah, it'll be these nameplates here. Well, you don't need Julie, she's the moderator. No. Okay, on the speakers. Yeah, they're all speakers. Andre second.
And also, I know that there are alternatives. Kumar or another one. So it'll be Kumar.
It'll be Kumar. The alternatives are there in the corner on the floor, but we don't know. This is correct. So correct.